host, and I'm going to moderate this general session. We have a great panel of speakers with us here today for part 2 of our special series on preventive medicine. We had part 1 at our last meeting in July, which was somewhat of an overview of preventive medicine and on how early expenses prevent significant later costs. And now we have part 2, focusing on themes such as food as medicine and advancing a healthy America. Thank you to Representative Oliverson, NCOIL President, for spearheading this series. As you may know, food as medicine is a concept that refers to the idea that food and nutrition can help prevent disease, sustain health, and treat certain conditions. This approach is part of the overall saying that prevention is the first rule of good health, and it can be a valuable tool to advance a healthy America. As the panelists today will discuss, there are different ways states can implement different programs to meet this goal. And there are also other things that we as policymakers need to be aware of that impact overall health, such as food safety, vaccination rates, and the use of federal waivers to make innovative approaches in preventive care more available to everyone. Joining us today to discuss these issues are Sharon Lamberton of Pharma, Greg Thompson of Wellpoint, Texas, Barbara Kowalczyk of the Milken Institute of School of Public Health, Martha Roerty of Advancing States, and Brenda Gleason of M2 Healthcare Consulting. To learn more about these speakers, you can view their bios in the program and also on the app. I urge you all to reach out to them afterwards to learn more about them and about these important issues. In terms of format, we will hold all questions until all panelists are finished speaking. Let's get started. We'll first hear from Sharon. Please go ahead.
Good morning, Senator Boyd, and good morning to this committee. Thank you for being here today to discuss this very important topic for our industry. I'm a nurse by training, and I'm back in home, Dr. Oliverson. I graduated Texas Women's University, as you know, in Houston, and I'm really happy to be here because of the healthcare disparities is something that affects all of our communities, and our industry is really doing quite a bit to address this. And I want to make sure I give you that and then some solutions because you're here. What are the best practices to improve health equity? And I'm going to go to the next slide, if you would. Is somebody advancing it or do we have our thingy? Thank you. Do you mind if I grab that? Thank you. Sorry, I should have located that. So just a little bit about pharma. We represent 30 drug companies that make brand name medicines and pharmaceuticals that cure and save lives and improve lives every day. Good news is that we have 900 medicines that have been approved since 2000 and 8,000 in the pipeline. 5,000 of those are here in the United States, which is exciting. We have a great pipeline and expect some good medications that are approved next year. We spend over $1.1 trillion in research and development. It's a tremendous amount, but it is worth it, as we know. Interesting slide here because a lot of people don't know that there are 3 phases to clinical trials. As I mentioned, I'm a nurse. I worked at National Institutes of Health in neurology, and I was blessed to see a drug come from bench to bedside. It takes 12 to 15 years on average to bring one drug to market. 12 to 15 years, and on average, $2.6 billion. And 88% of those fail. 88 in that pipeline, and 95% of vaccines fail. So we're in a risky, expensive, long road business, and we need state policies that will help incentivize our companies to continue doing what we do best. And the patients need us and providers need us. But it's interesting because I really wanted to bring home how this is important and in your role as state legislators to ensure that we have a good environment for innovation is so important. A lot of folks don't know that research and development goes way beyond those 3 phases. It actually goes into phase 4, monitoring the drug safety, and then also some of the drugs that are approved for a condition are later approved for different conditions. In fact, when we look at cancer, it's amazing because we look at cancer, there's 60% of the approvals have really been, 60% have been approved 10 years ago, now have additional indications. And we're seeing that with the GLP-1, for obesity, we are seeing additional conditions being approved for that, cardiovascular disease, kidney disease, and even Parkinson's. And we have 6 more in the pipeline for that. So our companies are working hard to really address obesity, which is an important piece to what we're talking about, which is social determinants of health. When we look at the social determinants of health, it matters. Everybody knows where we work, where we play, where we pray in our communities. We want access to healthcare providers and medications. While we work hard to bring a medicine to market, it does no one any good if you have no access to it. And our low-income, vulnerable communities have problems getting access to medications. And I'm going to talk about some programs that we have in a minute for access and patient assistance. But where access comes into play for us are pharmacy deserts. And I know Senator Boyd knows all too well as a pharmacist and a strong proponent of access to good treatments, that 40% of patients have to drive over 15 minutes to a pharmacy, and some even over an hour. So we're seeing the independent pharmacies reduce dramatically, and we want to make sure we're getting our medications to patients, because it really does matter and will help reduce chronic disease if folks take medicines as prescribed. About $216 billion could be saved if patients took their medications as prescribed. But again, if you don't have a provider to write that prescription, it doesn't do us any good. But where we care is where the clinical trials. We want to make sure that those clinical trials that I addressed on slide 3 with the phase 1 through 3 has enough diversity in them. We want diversity not just of race, but we want it on medical demographics, such as, do we have enough obese patients? Do we have a profile of respiratory diseases? We saw this come to fruition through COVID. We didn't have enough diversity in our clinical trials. So all of our 30 companies voluntarily came together on clinical trials and really committed to recruiting and retaining patients for clinical trials. And that's really important for us, that you have access to those clinical trials that hopefully lead to a cure. Then we look at progress that's being made. There is some good news, but we have a long way to go. Since 1985, with the Heckler report, we've seen a 15% reduction in uninsured among Black and Hispanic patients. We've seen 100,000 fewer deaths since Part D, as in dog, drug implementation in 2003. We've also seen 800 medicines now in the pipeline for vulnerable patients and impacts those that are diverse. So there's some good news on here as far as what we're doing, but what really is going on with our industry as a whole. Every one of our companies has something very good going on in diversity and equity, but our industry has 3 pillars I'd like to leave you with. One is the health equity space. We are very engaged in CARES grants that have been administered in some of your states. We have over $1 million that have been awarded largely to healthcare providers, but that people that are doing innovative things to reduce hospitalizations and improve health outcomes and reduce healthcare costs. So those CARES grants continue to be awarded. In fact, we have just a review and distribution in just last month. We also are working on social determinants of health in a health equity tracker with Morehouse. And it's showing where chronic disease, how much diabetes is in a district or a zip code or your state, for example. And that's extremely important, I know, to you all. And then finally, with the STEM, we don't have enough people of color in the STEM pipeline. And this is important because we started a virtual at one point, and now we have a hybrid meeting where people are coming in and it's virtual. But 21% of the scientists and those interested in joining the industry have been hired. They came to us because sometimes our companies are a bit behemoth and it's hard to be able to break in the door. And we have this STEM program that's super helpful, not just for undergraduate students, but for graduate and people that have careers already that are interested in entering the biopharmaceutical space, which now employs over 5 million people. And I have a state-by-state breakdown on how Many people are employed in the industry in your states, should you be interested. And we also are working on something we call EQB Med, which is Equitable Breakthroughs in Medicines. And this was a $10 million grant that pharma provided that gets distributed to 10 sites that are ensuring that we're getting enough clinical trial diversity, that we're ensuring that we're getting enough representation in those drugs that are being created and researched and hopefully brought to market. And this is really great because we've had some new announcements of new sites that have been approved. And I just wanted to touch on that because it is in the backyard of many of you all. So one of them is in Texas. And in Texas, we've seen over UTMB and Texas Southern University are the two recipients for that initial site. And then we have also in South Carolina, MUSC is the recipient. In Tennessee, we also have incredible recipients that are I got to get that one. I don't have Tennessee. And in Grady Memorial in Georgia. But this is something that's going to go on. It's supposed to be able where people are getting best practices and passing this on to those that are interested in getting more clinical trial retention, because we have a bad history, as you all know, of getting patients' trust. And it's very important that people like Dr. Oliverson in the community and trusted providers that they recognize are able to talk about what a clinical trial is and dispel a lot of misnomers. We have also people in the churches and synagogues that are interested in helping explain what a clinical trial is and that you are not a guinea pig. You have rights. There are instructions that should be well covered, and it is written on an 8th grade level. So it's really important as a neuro nurse that I've done a lot of clinical trials myself at NIH that patients realize they can drop out at any time, but it doesn't do the science any good or the patient population that could benefit or even them. And if we can get them to understand what they're engaged in, it's all the better. And we also have, I've just drilled down a little bit more on all the health equity work that we're doing, the health equity tracker. The second one was the talent pipeline diversification, which again continues and has hired 21% of folks in our companies, which is so great. And then we have the clinical trial diversity principles. We're working to eliminate those barriers and the mistrusts from the past. And I'm just skipping through to the very end because I know that we want to reserve some time for the others and of course Q&A, but this is the one slide I would ask that you really pay attention to because www.mat.org is an important one-stop site where it includes 900 public and private programs that offer assistance to patients. You as a son or daughter or me as a nurse can help people get medicines to their door or to their provider by simply putting the names of the medicines in, and it will help get those free or nearly free medicines to patients. And a lot of people don't know that, even healthcare providers. So we try to get the word out on that we do want to make our medications affordable and accessible. We know with the health plan design issues that we are not able to do that. And a lot of patients, as we just heard earlier this morning, experience tremendous utilization management barriers where prior access is a problem. Step therapy, you're having to fail first. And that's ridiculous because when patients need it, the provider should be able to get it for them. And there shouldn't be an obstacle with that. And we have $23 billion in patient assistance in addition. So that kind of is the overview and the picture of what we're trying to do with reducing healthcare disparities, improving outcomes in communities, and making sure that the research and development of our medications has the diversity and profile in those clinical trials. And I have pharma.org/equity, but I'll be here throughout the day. My wonderful colleagues, Charisse Richard and Brenna Clark are here. They're the point people at NQuail that you've seen before. And if they would raise their hands behind me, just to identify them, they're here to answer any questions as well. But thank you for your time. And I really want to thank Senator Boyd because he passed key legislation called Share the Savings, which got patients medicines at the point of sale, and premiums have not gone up in Arkansas. A lot of people said, oh, that's going to make the premiums go up if you do that, and you share the rebates where over half goes to other supply chain stakeholders. And Senator Boyd was not just a cheerleader for that. He was the sponsor of this important legislation. And it's only passed in 3 states, and it's West Virginia, of course, Arkansas, and Indiana. But that is a solution to something that you all can bring to your states, and I am happy to talk more about that. Thank you for your time.
Thank you, Sharon. Greg?
Good morning. I get the clicker?
Yeah.
I'm assuming
Your
it's
turn.
next. All right. So my name is Greg Thompson. I am the president of WellPoint, Texas. If you don't know WellPoint, we were previously known as Amerigroup here in Texas. We rebranded back in January, and we've been in this state for over 28 years, serving the Medicaid populations, both the young and the elderly in Texas. I'm here to talk about Medicaid preventive services. I think we should have retitled it saying Making America Healthy Again. I love the hat, Chairman. You got to tell me where I can get one of those. And thanks to the panel for spending some time on this very important matter about how we can make sure that the whole health of individuals are met. 80% of healthcare happens outside of your traditional healthcare setting. This is outside of a physician office, outside of a hospital, or an outpatient clinic. It is access to all types of services. We like to call it whole health at WellPoint. That is access to your primary care, your physician services, your pharmacy services, and behavioral health services, in addition to the non-medical drivers of health. Those are things such as food, employment supports, housing, transportation. All of these things are important to make sure that we are meeting the whole health of our members. For me personally, I know that when you do this and when you execute it, you do it, and the individual actually is living their best life. My wife has a rare genetic condition. We're actually seen at the NIH. I know Building 10.
Yes, that's where
I know Building 10 inside and out. She has a rare genetic disease, and for her to live her best life and to do the things that she wants to do, it's not just having access to a primary care provider, her neurosurgeon, her pharmacist. She actually knows her pharmacist by name, which is hard to believe these days, but she knows her pharmacist by name. They exchange Christmas presents. She needs access to a peer support group. She gets that through our local church. She needs access to a gym. She goes and works out to keep her body physically healthy. Transportation sometimes is a challenge for her because some of her tumors may be causing some problems where she's not able to drive. But when all of these things start coming together, and especially food too, when all of these things start coming together, Melissa can live her best life. And if you met her, you would not know that there was anything clinically wrong with her. But if one of those things come out of balance, then she is not living her best life. And it impacts not just her, but the entire family. So it is critical for us to make sure that we are focusing on the whole health of our members so that we can make sure that their personal health goals are met. We like to talk about personalized medicine. We call it person-centered care and individualized care plans. Each one of us in this room, for us to get healthy and to stay healthy, it looks a little bit different. This weekend, I got a black eye. Yes, I got a black eye, and I did not go to the Tyson fight. I was out on a tennis court playing tennis and got hit in the head with a racket and got a black eye. I was trying to stay healthy. I played tennis for over 30 years, first time ever. What did I learn about that? Getting healthy and staying healthy is hard, and sometimes it hurts. So this is why the non-medical drivers of health are critically important to help somebody get healthy and stay healthy. So I want to start with medical loss ratio, and I know I'm sitting in a room of experts, but we'll quickly run through this. So I just spoke about why these things are important. Let's talk about how do we actually include these types of services into medical expenses for health insurance companies. It starts with the MLR. So MLR, by definition, is medical claims over the capitation payments. We also include in the medical claims some quality performance initiatives, and dollars can go into there, and then taxes and fees and things like that come off of the payments. But it's a very basic calculation of cost over revenue coming in. And what we would like to see is those non-medical drivers of health being placed in the upper side of the equation into the medical claims so that we can make sure that we're meeting each individual where they are. So for Medicaid, on average, when we talk about MLR, I think this is really important for this group to know and to understand. MLR on average is about 85% in healthcare cost, and then about 15% in administrative cost. So you may be asking yourself, are there any guardrails here for other types of things? And the answer is yes. So in Texas, the state of Texas uses something called a profit share provision. So after an MCO has made a 3% profit off of their medical claims, then we start sharing those profits back with the taxpayer. Some states call these collars. Lots of different ways to do this, but there are protections in most states for Medicaid as to what expenses can be placed into the Medicaid cost. So as we think about non-medical drivers of health into the MLR, know that there are those guardrails to protect over expenses into these buckets. Next is, how do we actually go about doing this? I'm going to say it's pretty straightforward, but I know it's really, really hard to do this. But at the state level and federal level, we can make sure that we can add these particular types of costs into the MLR. I was talking with Chairman Oliverson a few minutes ago. We can also put these into clinical outcomes. So make sure that if you are spending dollars into these types of services, and I'm going to speak on food very quickly, that we are actually getting clinical outcomes that are lowering the cost of care. And so for WellPoint and for Elevance, our parent company, we are advocating both at the state and the federal level to place these types of expenses into the medical cost in the MLR. So what are we actually talking about? These are some programs that are specific here in Texas that I'm very proud to share with you. First is a Food RX program in partnership with the Houston Food Bank. This is the first of its kind in the state of Texas. We have partnered with the Houston Food Bank and local community clinics to actually provide food prescriptions for patients. Yes, I said food prescriptions. An individual can walk into a physician's office for a common cold, for immunization, for whatever they're walking into, and if that physician sees or the individual expresses food insecurity, they can write a prescription for food. And that prescription can be walked over to the Houston Food Bank, and that individual can get a fresh box of food. That box of food does not go against the individual's federal allowance. The federal allowance is 2 boxes of food. Often that's not enough to feed a household, and so extra food throughout the month is needed. So we're very proud of this partnership between the Houston Food Bank and multiple clinics providing access to food for individuals who need it. The next is a program that I'm very proud of. I was a cancer researcher in a previous life, and a hospital administrator, so I love data. I love models and pilot programs. Women's health in Texas has been a focused area. I'm chairman of our local March of Dimes and have been for the last decade, so women's health is certainly a passion of mine. And we knew that we wanted to make some impacts on women's health in Texas. One of those things that we wanted to focus on is gestational diabetes. We knew that that was a challenge for a lot of our moms, and gestational diabetes often ends up having NICU deliveries, babies who are premature needing to go into the NICU. So we wanted to figure out how can we support moms across the state in moving into gestational diabetes. So we put in place a food as medicine program. So we selected a couple of hundred women who we thought were high risk for gestational diabetes. We sent them 3 meals a day that were frozen, that were diabetic-friendly meals, and we expected that the gestational diabetes rate for this population was actually going to be lower than the control group. Well, this actually failed. When we actually looked at the results, we didn't see any change in gestational diabetes. So you may ask yourself, why am I here talking about a failed program? Well, what actually came out of it is I asked our team, let's continue to look to see what else happened. Well, something phenomenal happened. This particular group of pregnant women had a 70% increase in postpartum visit adherence over the control group. 70%. That's huge. And we also saw that their children, their babies, had a PCP, and those the children kept their appointments, their immunizations were actually given on time, and so it was all of the care after the delivery was done well. So we asked, how did this happen? Well, one thing that we did in this particular pilot program is on every single frozen food package, we had health tips on top of them. And those health tips were things like, this is why you need to go see your OB after you deliver. This is why your child needs to get their immunizations, and here's the schedule. Here's how you can get more health information. So we had health tips on top of those food boxes. So 3 times a day, mom was looking at that as she was microwaving her food, she was reading the top of that package. And we believe that that is the reason why those other health outcomes actually happen. NICU rates were actually lower, so this is one of those food as medicine programs where we got significantly improved health outcomes and lowered cost of care. Next, I'll quickly run through these. This is an elaboration of our food as medicine programs in medical clinics. We place across the state in multiple clinic practices these food pantries. This is a refrigerated food box where multiple food boxes can be placed in here. We partner with clinics across the state in areas that are underserved in that particular community, and we partner with the local food bank, and we put food boxes in medical clinics so that those boxes can be provided to patients as they walk in the door facing food insecurity. We also know that in Texas is absolutely huge. I live out in West Texas, and I would absolutely encourage any of you, if you're here from out of state, come back to Texas, go to the Big Bend, go to Presidio, that's here pictured here. You can go and see the beautiful state of Texas, but it is rural. Presidio is right on the border of Texas and Mexico. The closest healthcare facility is 450 miles away. It is a long distance away to the next urban Trauma One center for them. And food is a challenge. And so we place food gardens for them because there's not a food bank local in Presidio. So we need to help the individuals in the community grow their own food. And then also we have areas where we have mobile food pantries to go out in surrounding areas in rural Texas, again, meeting individuals where they are and where their needs are. The particular The Presidio Community Garden is actually one of our highest producing gardens. Thousands and thousands of pounds of produce are produced in that particular garden, feeding the community of Presidio. Now, these are all great, but I want to make sure that you can hear directly from our community partners and community individuals about what food means to them and how it impacts them. So if this works on this click, I'm going to share a video with y'all. Maybe? Do I need to click it again? I don't know. Let's see. Perfect.
We are here at Covenant Children's Hospital in the nourishment room. The nourishment room was a project that WellPoint partnered with Covenant Children's Hospital and the South Plains Food Bank to bring to life.
Our social worker was like, hey, we have a lot of families within our own NICU that are food insecure. And what can we do about that?
The hospital contacted me and needed a better way of feeding families. Their challenge was that they were seeing families not getting proper nourishment as their child is healing in the NICU unit.
Food and nutrition is one of those basic needs that you need to help cope with that emotional stress that you're having.
When they introduced this program to us, it was a sense of relief for us. I didn't want to leave her. She's panicking. We're first-time parents, so it's been super helpful for all our needs.
There's no family in greater need than a family who has a child that's in the NICU.
It's tough. It's 24/7. You're sleeping at the hospital. You're not going home.
I was the middleman. I was jumping back and forth while she was recovering and while he was back there. So no sleep, but for me, it was a sense of relief that I can quickly get her something for her to eat and then run back over there to make sure everything is okay.
This nourishment room makes sure that mom and dad stay well nourished, that mom heals appropriately and has great nutrients to breastfeed her baby.
Everything in there has nutritional factors for her.
Food is medicine. It is. There is no better medicine that only that mama can provide for her baby.
This is a luxury that we're blessed with for having this kind of help. Because in any crisis they're in, the last thing people think about is eating.
I mean, it's just incredible to hear the stories from families about how this has positively impacted probably one of the most stressful experiences that they'll have in their lives. So WellPoint is so grateful to be a part of this partnership.
It's 3 different organizations that came together for the same purpose, the same mission, and that is to help families in a really difficult situation have some of their basic needs of nourishment met.
And when you have a baby that's in the NICU and you're more worried about someone else's life than yourselves, this is what we need.
So it's a proven fact that NICU babies who are fed breast milk actually have shorter length of stays and better health outcomes. What better way than to make sure that mom is well fed while in the NICU? So I thank you for your time today.
Thank you, Greg. Barbara?
Thank you very much to Senator Boyd and to the committee for inviting me. My name is Barbara Kowalczyk, and I am faculty at George Washington University in the Milken Institute School of Public Health. I'm an epidemiologist and biostatistician by training, and I lead the Institute for Food Safety and Nutrition Security. My main focus area is on food safety. But I think it's really important that we think about the integration of food safety, nutrition, and food security in different ways than we have in the past. So I wanted to talk really quickly about the focus areas of food as medicine. I'm going to say, and quite honestly, this may not be a popular opinion, but the food as medicine actually makes me fairly uncomfortable as somebody who's been working in the food arena for 20-some years. The fact is that I view medicine as reactive, and we should be focusing on prevention. Also, if you think about medicine or food as health, we have all of those. Overconsumption of food can also be a problem. So I'm not going to focus on that today. I really want to focus on food safety, because it's an area within the food as medicine movement that gets very little attention, and it really needs to be. So you can see here from the Academy of Nutrition and Dietetics, there are 4 focus areas, and one of them is promoting food safety, which is what I'm going to focus on. So many people don't know that foodborne illness is a serious public health issue. It causes about 600 million illnesses per year globally, 420,000 deaths, and 33 million healthy life years lost per year. That's on par with the burden of malaria, tuberculosis, and HIV/AIDS, but gets only a fraction of the attention. A lot of people also think of foodborne illness as a bad tummy ache, which I'm going to talk about here in a few minutes, but it's associated with many long-term health outcomes, and we know that infectious diseases do have an impact on immune systems and can contribute to non-communicable diseases, as well as our gut microbiome. Vulnerable populations bear most of the burden, that is children, particularly those under the age of 5, pregnant and postpartum women, senior citizens, anyone over the age of 65, and anyone with a compromised immune status, such as a cancer patient. And these illnesses have significant economic impact in terms of medical costs, lost productivity, loss of consumer confidence, reduced market access, and increased food loss and waste, which is really important when we think about how we're going to feed our global population in the coming years. So as I said, foodborne illness is really more than a bad tummy ache, okay? Most people think of it as something that sends you to the bathroom for 24 hours, right? Diarrhea, vomiting, nausea. But a foodborne illness can actually increase your risk of developing reactive arthritis. It is a common trigger for Guillain-Barré syndrome, particularly Campylobacter, which accounts for 40% of cases in the United States. Guillain-Barré syndrome causes paralysis and death. It's also associated with several digestive disorders, including irritable bowel syndrome, Crohn's disease, ulcerative colitis. Particularly in pregnant and postpartum women, you can see neurologic disorders. If a woman is pregnant and she is exposed to Listeria monocytogenes or Toxoplasma gondii, you can see the baby is born with cognitive impairment, visual and hearing impairment. You can also, from several foodborne pathogens, have secondary seizures and epilepsy develop. Renal failure and associated sequelae is probably the most well-recognized. So Shiga toxin-producing E. coli can cause a condition called hemolytic uremic syndrome, or HUS. It is a very severe, life-threatening illness and the leading cause of acute kidney failure in children under the age of 5 in the United States. And children who survive this condition often deal with chronic kidney disease, end-stage renal failure, chronic hypertension, pancreatitis, diabetes, and so forth. There's also emerging evidence from both Johns Hopkins University and GW that schizophrenia and psychosocial disorders have been found exposure to Toxoplasma gondii has increased the risk of those, and there is increased risk of urinary tract infections. A significant proportion of those have been traced back to foodborne pathogens. Also, we often don't think about, and I will say, I'm in the exercise and nutrition department and environmental and occupational health departments at GW, but often food safety and nutrition are not viewed at in a holistic manner. So if you look here, unsafe food can really impact nutrition in negative ways. First, somebody could consume unsafe food, and that will cause disease, all right, an acute disease, which can lead to the inability to absorb nutrients. It can also result in chronic sequelae, which all lead to poor nutrition. You can also try and control unsafe food, and that can impact nutrition in a negative way. So the way we control unsafe food is lots of times we process it into other things. We cook it and put it into processed meals. We can recall unsafe food, or discard it, and that decreases the availability of food. Not only that, the recalls and outbreaks that happen can lead to consumer avoidance of certain foods, and these can indirectly lead to people substituting less nutritious foods or other nutritious foods, which can ultimately lead to decreased consumption. And I'll talk in a few minutes about some of those examples. One of the challenges that we face is our most nutritious food is also our riskiest food. So fresh produce is the riskiest food from a food safety perspective. The recommendation is that half your plate be fresh produce, but fresh produce accounts for about half of foodborne illnesses in the United States, and there's typically no kill step. You often don't cook fresh produce before you consume them, and that's how you kill the bacteria. Animal sourced foods are also really important because they're energy and nutrient rich, and they count for about a third of foodborne illness disease burden. Cooking and safe food handling practices can reduce risk, but I would like to ask you, how many of you own a meat thermometer at home and use it? That's one of the problems. You cannot tell whether products have been safely cooked without a meat thermometer. Visual cues are not reliable. And of course, this is even further complicated by the fact that we have a really complex food system. I love this chart by the National Academies of Science, the well-traveled salad. The reality today is that a single meal could contain food or ingredients that are grown, processed from around the world. And you can see that here in this graphic. So it makes it really hard to manage risk. And that's what I spend most of my time thinking about, is how do I manage risk from a food safety perspective. So it's not entirely surprising that we have food safety events all the time. I mean, we have ground beef recalls. There's recalls. Leafy greens is one of the most commonly recalled or outbreak associated products right now. There was one recently, the kit that I have up here, it was actually, the problem was the cheese in the kit was contaminated with Listeria monocytogenes, which can be very, very deadly for pregnant women and our senior citizens. We've had several E. coli outbreaks related to walnuts or other ground nuts. We should not forget the Cronobacter outbreak in baby formula that led to a massive shortage. We had lead in applesauce that was largely distributed to children through dollar stores. And if you wonder why, it was actually the lead was in the cinnamon, and there's another recall happening right now due to this. So spices are sold by the weight, and lead is heavy. So this was an economic adulteration. It happens pretty regularly, and we import a lot of our spices. And I personally say it's like the wild, wild west, right? But lead exposure in children is extremely detrimental. So we need to be very careful about that. Of course, I'm sure everybody knows about the boar's head outbreak that's happened this summer, Listeria monocytogenes. I'm going to say that was a massive failure on many fronts. I could probably do a whole hour-long conversation on that. And in my opinion, what they did was criminal. Another example is H5N1. We hear a lot about egg shortages and egg prices. H5N1, avian influenza, is the problem. And we're probably all facing that this coming week. And then the last picture I put on here is really about food insecurity and food banks and food pantries. This is a picture from during the COVID pandemic, and people were stepping out to, lining up to get food. And the one thing, I know it's hard to tell from this angle, but if you look at that picture, everybody's wearing shorts. And that means it's hot outside. And that food has been sitting out all day. And I would like to mention, I think food banks and food pantries are really important part of our food system, but they're unregulated. Food banks and food pantries are not inspected. I had a student go out and tour a select group of food pantries in Columbus, Ohio. I used to be faculty at Ohio State, and we found significant time temperature violations in the food pantries. Now, you take someone who is food insecure, and you expose them to a foodborne pathogen, and they do not have good access to health care, They do not have paid sick leave. They're probably working in the food industry themselves. One case of diarrhea that lasts 2 or 3 days is a problem for them. And so we need to do a better job at educating people who are working with the food insecure about the risks of food safety. Here in the United States, the cost of foodborne illness is pretty significant. We have an estimated 48 million illnesses a year, 128,000 hospitalizations, and 3,000 deaths. This results in a little over $17 billion in medical costs and lost productivity, and that does not include those chronic health outcomes that I said were associated with foodborne illness. So on the medical side, it's pretty significant. It's also significant on the industry side. The average cost of a recall is $10 million, okay? And that doesn't include the impact to a company's brand, right? So you can see here the graph of what happened to Chipotle after they had several E. coli-related outbreaks. So I'm going to wrap up by talking about food safety is really a shared responsibility. We say it goes from farm to table or farm to fork. I like to say it goes from farm to fork to physician. Our physicians our healthcare providers are the first responders to foodborne illness, but most of them get maybe a 10-minute part of one lecture in medical school on this. I've seen very well-intentioned physicians and healthcare providers give very bad advice around food safety that can increase risk to patients. So how do we prevent foodborne illness from happening, particularly in this environment? Well, we use a multi-hurdle approach, very similar to the Swiss cheese model that you saw during the COVID pandemic. So we need producers to do their job, growers to do their jobs, processors, retailers, regulators, and consumers all need to do their part because we know none of the interventions that we have are 100% effective. So what can insurers do? I can only say I was really thrilled to be invited to this meeting because for the past 20 years, I've been trying to engage people that are interested in insurance in this topic. It's been a hard, long road. But insurers are an important but overlooked stakeholder in the system. And product contamination and recalls, as I already mentioned, can have severe consequences both for consumers and local economies. Underinsurance is a big problem. How many of you remember Chi-Chi's or Sizzler? They do not exist anymore because they had inadequate insurance when they had a major outbreak. Jack in the Box, I don't know how many of you are familiar with the 1993 Jack in the Box outbreak that sickened 700 people and killed 4 children. That happened in 1993. About 6 to 12 months before that outbreak happened, their board decided that $50 million was not enough in insurance, and they raised their insurance to $100 million. That outbreak came in at $98 million. Jack in the Box would no longer exist if they did not have adequate insurance. Okay. Now, one of the challenges that we have is that the insurance industry doesn't have the food safety expertise to inform their clients, particularly small and medium producers who are critical to our local economies and our food systems. They don't necessarily have the expertise available to them to be able to give good recommendations on the amount of coverage that should be carried, both in terms of general liability, product liability, spoilage, contamination. I don't deal with liquor, but I know that's one of the food liability insurance types. And many people, many producers, even if they're exempt from federal regulations, in order to supply some of the biggest retailers, have to have adequate food safety programs and product liability insurance to be able to be a supplier and access those markets, and lack of that can be a real problem. I do think the insurance industry and insurance regulators can create incentives for compliance with food safety regulations and best practices. Some of my colleagues in the food industry have said that often, they get buybacks or rebates when they implement new food safety programs and they don't have outbreaks and recalls. They can take that money and reduce or reinvest in their food safety programs. And I think the insurance industry can promote risk reduction strategies because they can give advice or reduce premiums when best practices are put into place. So kind of really, not really the final word, but I really like this quote, and I think it's something that we need to be thinking about. We are, and it's from Delia Grace, who works internationally, a colleague of mine on food safety, but the point is if consumption of fresh animal-sourced foods and produce were tripled without accompanying action to improve food safety, then the burden of foodborne disease would be likely to double or triple too, offsetting any health benefits from improved nutrition. And so my message to you at the state level, the states play an incredible role in food safety. A lot of our food safety programs that are overseen by FDA and USDA are managed at the state level or delegated to the state level. I've been advocating, there's been proposals for cutting funding to state level public health programs that involve surveillance of foodborne disease as well as oversight of food safety. And we've been advocating strongly that not happen because we are concerned that we will see food safety decrease. So with that, I really wanted to tell you the real impact of food safety. And these are all people who I have interacted with their families who have been impacted by foodborne disease. The top row are all people who have died from a foodborne illness. Kevin in the middle is my son. He died in 2001 at age 2.5 from eating food. He went from perfectly healthy to dead in 12 days. And I do what I do today because no one should ever die from what they eat. And I appreciate your time and attention and your efforts to improve the safety of our food supply. Thank you.
Barbara, thank you. I was looking forward to lunch, but now I'm not so sure. So, Martha, please.
Wow. I'm really also very privileged to be here today. I started my career at the National Conference of State Legislatures, so way back in the day, and I worked, when I started there, in budget and tax policy. And I realized as I was working there, I'm going to date myself, because it used to be that K-12 was the #1 driver of state budgets, and it just kept getting eaten and eaten and eaten by the Medicaid program. So I left after I went there and to the Governor's Association. I went and was the director of the Medicaid Directors Association, where I decided that I was still paying attention to the budget, and in the Medicaid budget, long-term services and supports started to eat the Medicaid budgets. And I really wanted to pay attention to that, and so I had the opportunity to transition to run the National Association of States United, State Units on Aging, I guess was what it was called back then. And now we are called Advancing States, which is the association that represents all state agencies on aging and disability services, primarily on physical disabilities and not on the intellectual and developmental disability agencies. Our agencies administer the Medicaid waiver programs, help to oversee the Managed Long-Term Services and Supports programs, and the Older Americans Act programs. And what I have noticed over my nearly 20 years in running this role is it is on the front end that we can save the most money. And so I want to talk to you about that. But first I want to say that about half the states work with us each year on a consumer quality of life survey that's targeted for both people with physical disabilities and older adults. And the top 7 things that come out year over year on their quality of life, and all of the individuals that we're surveying are either participants in the Older Americans Act programs or Medicaid waiver recipients, have nothing really to do with health in the traditional setting. or in the traditional sense. They're whether or not they can live independently and autonomously, making their own decisions and having a self of control, living in their own home and in their community is number one. Having social connections and relationships, having a sense of financial security, safety, that they have a sense of purpose and fulfillment, that they're able to go where they want to go when they need to go there, and that they have a house to live in. So it's, I think, already been stated, it's like 80% of the health outcomes are non-traditional, and the quality of their life is also the non-traditional. It's food, housing, transportation, and community. The programs that the states administer are, that help to do these things include the Older Americans Act, which is not an entitlement. It's a small program that is federal funded, but also administered by your local area agencies on aging through the states. Most states, not all, but most states also have a state administered program that is Medicaid light. It starts with the Older Americans Act, but then the Medicaid light looks like a Medicaid waiver wraparound. And they include things that are nutrition is the number one thing for the Older Americans Act. Supported services include the transportation, in-home services such as the personal care, homemaker assistance, chore. Case management is very important. It's the having the individual that can help to bring all those services and supports together in the community. And then evidence-based health promotion and disease prevention programs are also critically important to ensuring that individuals have physical fitness, that they learn how to prevent the falls, that they do understand how to manage their chronic disease and live healthier. I'm going to focus, though, on food because we saw no time during the COVID crisis. It really propelled how important food is to the overall health of the consumers, and we saw it nationwide. I want to focus also on the home delivered program in particular. During COVID, I am a volunteer for our local area agency on aging, and I volunteered during COVID because I was one of the individuals that was under the age of 60 and had fairly good health, and so they allowed me to be one of the meals providers. And I was delivering meals 5 days a week for one route, and I noticed the decline of the individuals that I was serving precipitously go down the longer they were socially isolated. However, I was only able to deliver one meal a day, 5 days a week, because that's what the Older Americans Act pays for. And if there's a snow day, there's no meal. If there's a holiday, there's no meal. And I think most of us in the room would say, we would prefer to eat more than one meal a day, 5 days a week. So I think that's an overall snapshot of what I saw personally happening. What we do know from feeding individuals with the Older Americans Act or with the Medicaid waiver programs is it does help to prevent malnutrition. And it also can help with individuals that have a chronic disease. The meals can be medically tailored that are delivered so that they are tasty but don't have salt, things that have more herbs and now I'm worried about that, but I'm going to say I'm a little worried about it, but it's an alternative to having the salt in there. And we do know that their outcomes on their health can be improved. They have less need for surgery and illnesses, and overall improves their well-being. The national average for a home-delivered meal right now is $10. $10 a meal is the national average. It also can help avoid unnecessary hospitalizations. Falls are the number one issue that we're facing in the United States with older adults. It causes a huge human and economic burden of approximately $80 billion is spent yearly on falls. It is growing. That number for Medicaid alone is $3.5 billion. It's on average $20,000 per individual that falls for just the hospitalization portion, not the nursing home and rehab portion. So I average that out for a $10 meal versus the falling. And the number one reason people are going to the hospital for a fall is dehydration. So I'm just wanting you to put that into perspective. It does also help, as I said, the home delivered meal program does help to combat isolation, and it promotes social interaction. Most of the times, the meal provider that's dropping it off does check on the individual. As I said, we're tasked with then telling the case manager if the individual looks like they need more assistance in the home or if they look like they're declining. It also gives the senior a sense of security because somebody is checking in regularly. I should also mention some of these are Medicaid waiver clients, some of them are Older Americans Act, but in general they both fall into the same place. It also allows the senior that is unable to prepare their own meals to have one meal that is already prepared for them. The last several years, congressional leaders have asked for reports to be written about whether or not SNAP is duplicative of the home delivered meal program. And I'm here to say no, because again, it comes down to, can the senior prepare the meal? Can the senior get out of the home even to buy the groceries to get the limited amount that they would get with the SNAP program? Again, there's an economic value also, as I said, not just from the falls, but also from all their costs of the malnutrition, and then it can also lead to the healthcare efficiency in the system. It also allows for volunteer opportunities for us, and it does have an impact to the local economy because the meal programs are relying on local vendors and suppliers, and it supports small businesses and it creates jobs. During the natural disasters, also, the meals programs are so tied in, and they are the ones that know where to find the individuals that have disabilities and the older consumers that we need to get out of their home and into safety faster. What actions can you take as state legislators? One, I'm going to dovetail and say we strongly agree that the Congress needs to change the medical loss ratio to allow the managed care companies to cover what they're calling non-health costs, but I call health because I think eating is part of health, under the health-related items and not just cover it in administrative costs. We really think that that would encourage more health plans to cover a more robust set of services and supports. I urge you also to consider asking Congress for additional funding to support the Older Americans Act programs so that we could feed more people. During COVID, we were able to see that we didn't have any state with a waiting list for home-delivered meals. Now I think we have all but 4 states have a waiting list for home-delivered meals, which is going to mean that those individuals are going to have a health challenge and likely will end up in the Medicaid program. That's more expensive than just offering them a meal. Nationwide, we can only serve, I think, in the Older Americans Act programs, we're not even able, given the limited funding, to get to 133% of poverty covering their meal. So I'd like to get to 133. That's a goal before I retire, which is a terrible goal to say because I don't want everybody to have to get impoverished just to have a meal. But that's my goal. Another thing is to encourage you in your states to talk to your Medicaid directors, your aging and disability directors, about whether or not they cover food in your Medicaid waivers. One thing we learned during COVID is about half the state waivers do not include food. There's a challenge here because in the Medicaid waiver program, you're not allowed technically to cover room and board in the HCBS waiver. That's only supposed to be included in the institutional side because it's called room and board. However, in the new technical guide from CMS, they do allow for up to 2 meals 7 days a week to be included because they see it as a cost savings. So we want to encourage the 25 states that don't currently have the food included in their Medicaid waivers to include the 2 meals 7 days a week for all the waivers. Some states have it in some waivers, but not all. We really want to include it for all. And then also talk to your aging directors to see if they've done comparative analysis to see if there's any duplication of effort for those that are getting Older Americans Act and Medicaid. Is there a way to streamline that so that you're not duplicating and wasting resources that could go to somebody else? With that, I think I'm going to turn it over, but I thank you for your time and attention to this really important issue.
Thank you, Martha. Brenda?
I would encourage everyone to wiggle around in your chair because we've been sitting here a little bit. Usually I would do a everyone stand up, but I will probably be the briefest. Thank you for having me. My name's Brenda Gleason. I run a company called M2 Healthcare Consulting. We do state health policy consulting in all 50 states. That's a little bit rare. There aren't lots of firms out there that work in all states. I'm not a lobbyist. And I get to work on all kinds of different issues, mostly working with state legislators across the country. So what I want us to all think about, based on the 2 panels you've heard so far today, and then thinking about tomorrow what you're going to hear in relation to the Chevron Supreme Court hearing, is what is the role of state government? What is the role of legislators? And not only legislators, but then who will decide? Your regulators, your agency heads, et cetera, et cetera. So the example I want to give today is vaccines. So millions of people in the United States are getting all kinds of vaccines, right? Everything from flu to hepatitis to RSV, et cetera. So millions of people are still actively, freely, transparently choosing that particular health choice. We don't have to tell them to do it. Lots of people are just doing it. So I want us to think about this like a stack. So here at the bottom of the stack is the person that is a consumer, not a patient yet. So we're making America healthy. We're focusing first on the consumer. Maybe most of us in this room that maybe you have very little interaction with the healthcare system. So the question, and much of what you heard today is, well, eating food, right? Or getting a vaccine, or making sure that you have access to transportation. These are things consumers do. What does the system need to do in order to support that person to make those healthy choices? That's where insurance legislators come in. So you heard, for example, from Greg that changing the MLR so that certain things are counted, right, as part of what they offer in insurance is allowed. That's where a vaccine comes in. So if a person's choosing a vaccine, for instance, we probably would want health insurance to cover that. That doesn't seem particularly controversial. What else we would need to do is to make sure we have enough providers that when a patient chooses that, when a consumer goes out and says, I would like to make this decision for myself and my family, that they have somewhere to go. That means pediatricians, that means office-based physicians, but also pharmacists are able to provide, especially adult vaccines. So again, an adult is choosing this. This is a study I worked on this summer with IQVIA, where we went and looked at what pharmacists were being paid across the country in Medicaid fee-for-service, and we compared it to then the rate of adult flu vaccination. So we were just trying to see, is there any kind of pattern when you pay providers to actually make a service available? Is it more likely then that that service has uptake? And you can see pretty clearly here, the answer is yes. So those N's represent how many states pay pharmacists. You see on the far right, above $20 to provide an adult flu vaccine, and then all the way down to the 5 states that pay between $0 and $4. There's no rhyme or reason. We're actually about to put out another study that shows this by state so that everyone can sort of see it side by side. There's no real rhyme or reason to red or blue states here. So some of the highest states include Montana, for instance, Colorado. Some of the lowest states include Hawaii and Arizona. So these are not necessarily falling into typical patterns. For the record, since we're here in Texas, they pay about $13 on the fee-for-service side. So where we would need to move, and what I want to encourage all of you to be thinking about as you go into session next year, is in a month and a half, or maybe now, some of you, pre-files are starting. Who should be deciding what's covered? And if you aren't using what is available in the federal ACA or federal agencies, you will need to create that in your state. So, who decides? What is it? How do you get health plans to cover it? We're ready for questions.
Thank you, Brenda. Representative Pollock.
Thank you, Mr. Chair. Thank you for your presentation this morning, and you're exactly right. This topic is kind of a hot topic in Kentucky, where I serve as a state representative. Our Commissioner of Agriculture, Jonathan Shell, is this is his big deal, and that's talking about food is medicine and what that truly means. What is healthy food? And where I'm headed to is the processed foods that are available now. I'll give you an example, obviously milk, and it's now broken down to 2%, 1% skim. And my grandparents literally lived off the farm with the milk cow, with the beef cow, with the hog, with the garden. She made everything. And I guess back growing up, I mean, we didn't know about dementia or Alzheimer's and all these other diseases, and it just brings up a lot of questions. And so our focus is back to the farmer providing that. When you talk about chicken and we got steroids just speeding up the process of our food, it just kind of makes you say, what's going on? And you bring up a great question on something that we have to decide on as legislators in the state, who is doing what, so we can fix it. And we can talk about everything involved, but the bottom line is, let's focus on healthy food, and then hopefully at that point, it's a trickle-down effect and people become healthy. Obviously, our choices of what we're putting into our bodies affects our health. And obviously, this day and time, like my grandparents, they worked all day long in the farm sweating, getting dirty, and doing those things. And obviously, I can't remember, be honest with you. I'm testifying right now that when's the last time I got out and got dirty and sweaty and burned, what that's all about. So, thank you for the presentation. This is a big topic, but I think the big target here is what we are doing to create the processed foods to speed up the process. And I just think back to my grandparents' table, farm to table that I grew up on. So, and again, going back to the processed milk, we send regulations and things back to our schools that not to provide whole milk, which is good fat for those younger children to have, is my understanding. And now we're taking that away for some reason. And so I appreciate your perspective on some of those comments that I've just made. Thank you.
Thank you. Assemblywoman Hunter.
Thank you. I'd just like to echo actually the sentiments that were just made. I thought it was interesting, this presentation. I mean, I have a district I represent that has a very high concentration of poverty, many food pantries, food kitchens, the food bank. I understand the concerns about not having the refrigeration, you know, that can cause illnesses, but what is glaringly missing in this presentation, which I thought would have been included, was maybe the FDA or somebody in here talking about the chemicals in the food. I can understand talking about, you know, the steroids in the meat, but red dye and every single thing that comes from some of these companies that put chemicals in food, food can't be medicine if it's not healthy. And I just think that we missed the mark here today in not having that conversation included, you know, relative to all of the chemicals that are in our food. We have manufacturers in this country making two sets of food products, one for us that include all the chemicals, and one for other countries that they say are banned in their country, but we're making it for them. And I think that's where we need to start. We need to have those people at the table and question why are chemicals permitted in the food in our country, and maybe that will be our pathway to healthy food for our residents in America. Thank you.
Thank you. Rep. Carter.
Thank you. I hope I have my mic on. First of all, thank you for your presentation. You know, you hit right home with me. I did prepare some notes. I just want to read them to you, let you know what I think. Impoverished communities are living in trauma. They are often housing and food insecure. 43% of Michiganders live below the ALICE population. And for those who don't know, the ALICE population are asset limited, income constrained, and employed. In other words, these are people who are employed, but they can't afford the basic fundamentals, food, medicine, etc. I live in a community that has no major stores, okay, where the homeless population is out of control. 35% of the residents who live in my city are either underinsured or uninsured. Each week they get in long lines and wait for food, and I'm so glad you mentioned the thing about the food being out in the heat or being out in the cold, and these are not inspected. But when you don't have food to eat or food to feed your families, that's your last resort. So you're going to put whatever is out there in your bodies. So it shouldn't surprise anybody that people who are living in poverty have high heart attack, strokes, and diabetes rate because they're eating what's put out there in the fields. So Martha, you hit on something. I think it was Martha who hit on the thing about our seniors. I want to tell you two things about happening in my community. I got a call from one of the local stores telling me that two seniors were coming in each week buying a small bag of dog food. When we found them and traced them down, we found out that's the only food they had. They were actually preparing this dog food, and it wasn't the only case. Another senior told me that they had come up with a creative way to create cat food in a meatloaf. So we live in one of the richest countries in America, and I think that this is something we can address because there is a large impoverished population in this nation, and just bringing up solutions to address poverty and through nutrition, because if we reduce the diabetes, the heart attacks, the strokes, the amputations, the visions, we will bring our health insurance costs down. And isn't that what we want to have? Accessible and affordable insurance. So I'd like to thank you for your presentation. I really want to thank you, Representative Oliverson, for doing this, because you hit something dead on the head. And for every legislator in here, this is a huge opportunity for us to go back to our communities and say, let's put something on the books that will make sure that people can have healthy, nutritious food. Thank you, and thank you.
Thank you. Rep. Bennett.
Thank you, Senator. Appreciate the other comments, and I certainly appreciate everyone's presentations. This is an interesting conversation, and I want to make a note that we tread a very fine line, I think, in talking about food as medicine, because it's obviously important that we eat healthier, and in America we have some bad habits. But part of that is that built into our economy, bad food is cheaper, healthier food is harder to access, and as you all adroitly pointed out, harder to make sure that it is healthy. how do we educate the public on the best practices in food preparation? And before that, how do we make sure that more Americans, including especially those who live in impoverished areas, have access to that healthier food? And the larger challenge, and I think that we're going to be dealing with it in the next few years, is as the federal government moves away from regulation in service of this idea that somehow the government is in this huge conspiracy to keep people unhealthy and sick through food. How do we combat that? And I guess specifically for this body, is there a way for us to regulate that through insurance when, as I see it, very popular national figures are continuing to confuse people and make them feel that there is this massive conspiracy. Of course, as a Democrat, I'm always amused at the conspiracies that we've been accused of, because my goodness, if we were really able to do that, control the weather, things like that, we would have a nicer day. But my concern is, as we have this conversation, if we're not specific about our role as a government, and if government is going to back away from this even more, and we're going to see more boar's head issues and more food contaminants, more lead in children's food, how can we, through insurance regulation, protect consumers? And I would love if anybody has any comments on that.
From my perspective, from a managed care organization, we do a lot of education for the members that we serve. A lot of healthcare education, the efficacy of vaccines, why it's important to go see your doctor for an annual wellness checkup, all of those preventive services. It would be, and it is very easy for us to add in how to eat healthy. Right here in San Antonio, we have a welcome room, and that welcome room is for any individual in the community, including our members, to come in and gain different types of education. We host healthy cooking classes there. One of the things that we know, we're in San Antonio, so there's a large Hispanic population. So when we have food preparation classes, we actually teach how to make Hispanic food healthy, and make sure that, again, kind of meeting the community where they are, and showing them how to cook food appropriately. We don't talk about safety as much. That may be something that we're going to add to the list. But I do think managed care organizations and health insurance companies definitely have access, and we have means and mechanisms to educate the population directly, both broadly and at a more community or individual level. And speaking about food is definitely something that we do today, and we can certainly do more of.
So thank you for the question. I don't know, I'm not an insurance expert. I don't work in the insurance industry, even in my research. But I think there's a couple of things. First of all, you cannot see, taste, or smell foodborne pathogens. And so, when we think about free markets, right, if I could go to the grocery store and say, well, this package of chicken contains salmonella and this one doesn't, obviously I'm going to buy the one that doesn't. But I can't. And so therefore I need government to play that role on my behalf, because I can't see it. I am likewise concerned. FDA, until the Food Safety Modernization Act passed in 2010, FDA inspected facilities under their jurisdiction once every 10 years. Now, high-risk facilities are going to be inspected once every 5 to 7 years. Okay, and that's going to be cut. All of food safety at the retail level is delegated to the states. So most of us, and the amount of food that we consume prepared outside the home is increasing. And if you look at, I'm in favor of educating consumers. I feel that sometimes too much effort is placed on that. Well, if only consumers would cook their food properly, or if only consumers would make a different decision. But when I go to eat lunch today, I have no control over the food I'm consuming. I have no control over what was what they purchased. I had no control over how it was cooked or prepared. I am fully reliant on somebody else to make correct decisions for me. And ultimately, I agree with you. I can't remember who actually said it, but cheaper, unhealthy food tends to be cheaper. I was talking to a colleague who was looking at small stores and food deserts. The soda was cheaper than the bottled water. And so, I think that is something that state legislators can get involved in. And particularly at the retail level, we are seeing state budgets around retail food safety is going to get cut. They're already, under this administration, talking about cutting $37 billion of FDA funding to the states for food safety. It's going to result in 200 to 500 lost jobs to go out and protect us when we go to the retail establishment. If there's a recall, everybody knows about the carrots, right? Baby carrots. Let me tell you, there are people, retailers, that still have those baby carrots on their shelves, and the states are typically the ones that go out and do recall checks and go out to the establishments and say, did you actually pull that product? And that means, these cuts mean that people aren't going to be able to do that. Also, we're seeing public health funding go away. That carrot outbreak was identified by state and local public health departments who are doing surveillance. So we may see things get better. I mean, everybody keeps asking me, why are we seeing more recalls right now and outbreaks? Well, we're doing a better job looking for them. Baby carrots did not become unsafe overnight. There have been outbreaks associated with baby carrots before, we just didn't know about it. So I think from a state level, I think there's a lot that insurers can do. In my experience, I've been trying for 20 years to engage the insurance industry in, they pay a lot more money for the outbreak and recall and the loss of product on the industry side than they do on the medical expense side. And so they have the power, actually more power than any of us do, to incentivize the industry to do better, because they want lower premiums. That's what they want.
Thank you. We've got 2 questions left, or until 1:30, whichever comes first. So, Assemblyman Gandolfo.
Thank you very much, and thank you all for being here today to add to this discussion. I would like to just reiterate some of the other comments made here about the chemicals added to our food. I wish that was something we were discussing more. Recently, California actually banned some artificial food dyes from foods being served in public schools. So I think it is a topic for discussion as we're discussing healthy foods and food as medicine. But one other thing, and I hope someone could share some perspective. A lot of parents, myself being a parent included, try to make healthy choices for their children in terms of snacks. And one thing I've noticed as I've started looking at labels more is there are so many foods that are marketed as being healthy and organic, but when you turn the box over and look at the label, there's as much added sugar as, let's say, a Kit Kat bar. So what can we do, whether it's promoting new labeling requirements or just promoting awareness for consumers, to check out what's actually in the food, even apart from chemicals, just the added sugar content and things of that nature. Because, at least to me, from a preventative standpoint, childhood obesity is a problem. It leads to other health issues, and even among adults, the risk factors increase with obesity. So what can be done to either raise awareness or update some of our labeling requirements?
So, so I think it's very challenging. So I'll give a little bit of additional backstory. I began my career in the pharmaceutical industry. I spent 10 years working in the pharmaceutical industry doing clinical research as a statistician. And so when I moved over to food safety after my son died, it took me a while to understand that the way we regulate food in this country is significantly different than the way we regulate drugs. But we put both things in the same agency. So as a statistician, I get into hypotheses and what's your null hypothesis and what's your alternative. So in the United States, we assume drugs are unsafe until proven safe. We assume food is safe until unproven unsafe. And that is a big difference compared to, say, Europe, which operates even for food under the precautionary principle. So I think one of the challenges we have is how we regulate food in this country, okay? FDA does not approve food ingredients. It's only when there's a problem does something happen. And that in and of itself is a challenge. Plus FDA is chronically underfunded. The food side is chronically underfunded. So when the pharmaceutical industry in the 1990s got the drug user fees through, they also got Congress to say that they didn't want, the pharmaceutical industry did not want them to be paying for all of the reviews of the drugs. So the requirement was that FDA, Congress had to appropriate more funding every year for FDA. Food does not have that. And if you look at FDA's overall budget, it is flat. And so what do? They reduce the budget on the food side of things. So that's a problem. I've personally advocated for splitting that agency in two, or at least introduce food user fees, which is a very unpopular thing, okay? But we have a budgetary imbalance at the agency that's causing some of these problems that you're talking about. Personally, I worry more about the microbial safety than the chemical safety, and the reason is E. coli 0157H7 can do in 7 to 10 days to a child what it might take 20 years to do from chemical exposure. Not to say that it's not an important thing. It is totally under funded and under-resourced. But the problem is that they can't even handle the microbial contamination, let alone get to chemical contamination and managing that. On the labeling side, I agree. I think that labeling is a big and challenging issue. The food industry is one of the largest lobbying groups in the country, and they want to limit the amount of stuff on front of package. I mean, I've been asked by policymakers, and I don't want to be on my soapbox too long, but I've been asked, why do pregnant women keep eating deli meats and soft cheeses and hot dogs? They shouldn't be eating those products. And my response to a regulator was, well, why don't you put a label on it saying, don't eat it? Pregnant women should not eat these products. And I was told that was not possible. So the food industry, and there's lots of good food companies. I work with lots of people in the food industry. They're trying to do the right thing. But I think government has to play a role in labeling and food oversight in a different way than it has been. And that has to happen at the federal and the state level.
Thank you. Senator McClendon.
Thank you, Mr. Chairman, and I'll be brief. And this is not so much a question, but I guess food for thought. In Mississippi, we have 82 counties, and one of those counties, up to recently, was what we call a food desert, did not have a grocery store in the Delta. No produce sold anywhere in that county. Now, one thing I have not heard during this discussion, convenience stores collect EBT. The little town where I live just approved its 18th convenience store. 18. Now, we're basically a city, but I still look at it as a town where the county seat. Our county is just below Memphis, so we're a suburb of Memphis. We're in the northwest corner of Mississippi. 5 major cities: South Haven, Olive Branch, Warren Lake, Hernando, and Walls. But we need to do a better education of our local officials, our Board of Aldermen, our city councilmen, our supervisors. Are we selling people's health and killing them just for a tax dollar? Now, believe me, I am all about capitalism. We are a true red state, a red county. But they just approved a convenience store across the street from our brand-new high school. Not even, one kid has taken a class there where they could get CBD, Kratom, a Coke. If they had a fake ID, they could get beer. No orange, no apple, no banana, nothing. So I think we as state officials, and I hope our municipality leagues, and Mississippi Municipal League for us, would do a better education of our local officials. Are we weighing healthy people or are convenience stores an inconvenience? Literally, we have two between 2 blocks, and it amazes me. But that's, it's time for lunch, and that's really all I needed to say.
Can I
Thank you,
make one
guys.
comment back to you on the convenience store? So I agree that there's a lot of poor choices that can be made in a convenience store. We have many food deserts in Texas, much like you do. We have actually leveraged the convenience store footprint to our benefit. We have placed what's called a corner store. We call it a corner store, and it's like an end cap of healthy produce. It's predominantly healthy. It's apples, oranges, bananas, and we've worked with certain convenience stores for those particular produce to be available for SNAP. So we want to make sure that if someone is walking into a convenience store, that they do have access to some healthy items that they can get at no cost for them. And so we have been doing that. It's been relatively successful, but like you said, you may have a banana, but also a Coke walking out. So, but I do think there is some benefit that can come from convenience stores.
And I have a final suggestion, although kind of sort of directly addresses it, but addresses some of the other questions. I think something that the state legislatures can do is leverage your land grant universities and their extension offices, right? The extension aspect of that is grossly underfunded. But there's a lot of opportunities. Most land grants and through their extension system have county extension agents, right, that can really help with this. But they're often overextended and can't really address all the needs that they have. So, I mean, I think that that's another area where funding those and working with those programs could really make a big difference, particularly in communities where you have food deserts or other issues at play.
Okay, seeing no more questions, then thank you everyone for participating. We really appreciate it. Up next is the Griffith Foundation Legislator Luncheon in the Villa Room, and then we'll meet back here at 2:15 for the Workers' Compensation Insurance Committee. We are adjourned.